Voice is audible, madam.
Yes, yes.
Yes, sir.
Audible only.
Yes, sir. Madam, we're not able to see your face, madam. Little, it's getting cut. Camera little direction, little adjustment.
Now all right.
Half is seen, madam. Up and down, little tilting. Yes, madam. Clear, madam.
This is not needed, I think. Okay.
Presenting a case of a 45-year-old lady, homemaker, a graduate, studied BSc, residing, hailing from Bangalore, a right-handed individual, presented with chief complaints of double vision since 1 month and slurring of speech since 3 weeks. History of presenting illness: patient is a right-handed individual with no known comorbidities, was in a usual state of health until 1 month ago when she noticed double vision, such that the objects appeared as two, but however they appeared one above the other. She noticed initially while reading the newspaper, and this double vision worsened on looking downwards and towards the left. However, this double vision disappeared on closing closing either of the eyes. Occasional head tilting was noticed by the attenders towards the right. There was no any nocturnal diurnal fluctuations or drooping of the eyelids that the patient noticed. There is no history of any associated pain, redness, or swelling in the eyes. This is like painless binocular vertical diplopia at this presentation. Next, 1 week later, patient also started noticing difficulty in speaking associated with slurring. She was able to comprehend, read, write, or speak and name objects fluently, but occasionally few words the patient and attenders noticed some slurring. However, during this time, the patient also had difficulty in making a food bolus and mixing food inside the mouth. There was no any aggravation or reduction of any of these symptoms. And the above symptoms remain non-progressive since the onset of the symptoms. Patient also gives history of COVID vaccination 1 month prior to the onset of symptoms. She had been vaccinated with Covishield. There is no history of any difficulty in chewing food, able to appreciate facial sensation. There is no history of any drooling of saliva, giddiness, any nasal regurgitation or change in the voice. There is no history of any dysphagia. Patient denies any history of loss of consciousness or any involuntary movements. There is no history of any motor or sensory disturbance or any bowel bladder disturbance. There is no history suggestive of any thyroid dysfunction. There is no history of any joint pain, rashes, recurrent dry eyes, or Raynaud's-like presentations. Past history: patient has no known comorbidities. There is no any prior hospitalizations or medication use. She has no similar complaints in the family members. Married life of 8 years. Completed family life. Children doing well. No history similarly in other members. Personal history: she consumes both vegetarian and non-vegetarian diet. Sleep, appetite are normal. Bowel bladder habits are regular. She denies any high-risk behavior. Summarizing the case, we have a middle-aged lady, right-handed individual with recent COVID vaccination, presented with binocular, vertical, painless diplopia associated with slurring of speech, with no other cranial nerve involvement or any motor, sensory, or autonomic or cerebellar disturbances. I would like to think anatomical structures involved, thinking mainly LMN lesion, thinking cranial nerve or at the level of nucleus or infranuclear level, thinking polycranialis neuralis. Differentials I would like to consider as infection, inflammatory, or neoplastic. In infections, thinking if there is any granulomatous lesions or retroviral disease. Inflammatory, thinking of sarcoidosis. And the neoplastic to rule out an SON.
Okay, so we will first describe the duration of illness is 1 month, no?
Yes, ma'am.
Is it okay? So first symptom is double vision, no?
Yes, ma'am.
So I am sure you know how to describe double vision. You have described most of the things, but I think you did not mention about. You have told no diurnal fluctuation.
No.
So supposing somebody is having double vision, for revision's sake, all of you know that whether it is uniocular or binocular. If it is binocular, it is most likely neuroparalytic. That means lack of parallelism of the visual axis. If it is uniocular, you will think of ophthalmic conditions, psychogenic causes, as well as occipital
corpus callosum, occipital lobe and corpus callosum lesion.
Yes. So what will be the typical features of uniocular double vision? One, it will present even when the opposite eye or even when the normal eye is closed, it will persist. Two, it will have a glare. It is coming usually from the cornea or lens, sometimes from the retina. So usually it will have a glare because of the refraction. It is due to refraction, so there will be glare. Two, it will not be a classical side to side or above or down. Usually it is a polyopia rather than a diplopia. Then, so, and when you look, you might find problems in the lens, or it may find glaucoma, or you might find corneal problems. If it is retina, generally it is not a diplopia, it is micropsia, macropsia. It is either small, too small, or too big. You don't generally find double vision in the macula. If in the occipital lobe and corpus callosum, you want to tell what is the thing you find in occipital lobe? That is visual association area, or in the corpus callosum, you want to tell means you tell.
Sliding hemifield defect, usually it will be altitudinal or sliding hemifield defect because communication in the corpus callosum is lost to the association area. So multiple parts of the visual field, they'll feel half of the visual field will not be there. So they'll see multiple parts of the same visual field.
What happens, you told, I think, but the newcomers may not be able to understand. That is sliding hemifield defect means, and there is another thing called double hemianopia. Your sliding hemifield defect is when the splenium of the corpus callosum is cut, you are having a right hemifield, you are having a left hemifield, but they are not linked. The field is there. So when the so because they are not aligned, it is not like that. The field is chart like that in a classical way. When both sides, nasal, temporal, they will not be aligned because they are disconnected. So in the area where the hemifield slide, instead of superimposable hemifields on both sides, when the splenium lesion is there, they are cut. So the fields slide over. It is not like the natural alignment. In the sliding area, the images become cut and appear as many, but most of them, the parts will be not complete because it is complete in the whole field. It is cut by the sliding field and appears as many overlapping images. So that is sliding hemifield defect. What is the other thing called double hemianopia is not a diplopia. Double hemianopia also occurs in the splenium lesion. Splenium lesion, you get two things. One is the sliding hemifield defect, because of which over the sliding two fields, partial images overlap and looks like polyopia or double vision. Whereas the other double hemianopia is you are having a right hemifield which is not communicating with the left hemifield, and a left hemifield which is not communicating with the right hemifield. Because of that, supposing you do the confrontation test, sitting in front of the patient, and you can tell the patient to point to the objects in the right hemifield with his right hand. That he will do. But when you tell him to do it with the left hand, because the information is not getting transferred, he will not be able to do that. For the left hemifield, he will do it with the left hand, but with the right hand, he will not. So that means the vision is there. He is not having a hemianopia at all, but it is a right homonymous hemianopia for the left hand and a left homonymous hemianopia for the right hand. But the field is there. Only thing it is, when you check with the right hand, right field objects are identified. When you check with the left hand, left field objects are identified. But cross identification is not possible. So that is why it is called double hemianopia. Hemianopia, when the information has to be transferred. So these two things are splenium lesion. So classical polyopia in the sliding hemifield is incomplete images sliding over one another and they are moving also. And occipital polyopia is again not a double vision, it is a multiple images and they do not have a point of maximum separation. Usually uniocular, multiple, not double, and you will not be, patient will not be able to tell when I am looking to the left or right, there is maximum separation of the true image and the false image. And in fact, the true and the false images are not distinguishable. You cannot distinguish one as a blurred image and one as a bright image and call it as a false. So that is uniocular. If it is psychogenic, again it is uniocular, but uncharacterized. Patient will not be able to characterize it in any of the well-known conditions like a glare in the retinal or lenticular problem, or the sliding hemifield in the splenium lesion, or the classical polyopia and the occipital lesion. But it's, I am seeing double. But classically, the double vision has got some characters which we described now for uniocular also that patient will not have. So that is psychogenic double vision. Next, you can have, so now your patient is having double vision, which is binocular. So you don't have to consider any of the uniocular causes. Binocular vertical diplopia, you said, no? So binocular vertical diplopia, you have two conditions. One is a skew phenomena. You see, skew. So before we call it as a cranial nerve palsy, we have to see whether it is a skew or skew phenomena. That's a head tilt. Skew also can have a head tilt. That skew happens in the pathways from the medulla to the midbrain to the is connection to the cerebellum. Anywhere it can have. So skew is vertical disconjugation of the eye due to supranuclear cause. That is an upper motor neuron. So generally double vision or squint. Skew means squint. So squint or double vision happens only in an element pathology. The exception being skew deviation. So skew deviation is vertical disconjugation due to supranuclear cause. This is due to vertical gaze pathway getting affected. And the point here will be, again, unlike
uniform
the
in all the areas.
Yes.
There is no point of maximal separation. It's uniform
so because it is supranuclear, there is no Hess principle of paralyzed muscle and non-paralyzed muscle. So patient will have diplopia, as Balaji said, it will be uniform in all planes. Whether you are looking up, looking down, looking horizontally, there is a vertical diplopia without any separation of maximum separation in any plane. And second, it is never oblique. The vertical diplopia of element cause can be oblique or straight up and down. So skew deviation is never oblique. So if the person says oblique diplopia, then you know it is element. Second, the diplopia remains constant in all planes of eye movements, that is skew deviation. And skew deviation also can have a head tilt. Head tilt is not against the diagnosis of upper motor neuron because it is the horizontal tilt center in the dorsal midbrain is one cause for the skew deviation. So skew deviation is a mechanism to study the depth of the material in three-dimensional, to get the three-dimensional view of the object in front without using the visual association area when the brainstem is getting disconnected from the visual association area. So it becomes like a lower animals trying to study the three-dimensional view. Like I always tell the housefly example, that will study the sugar solution by tilting his head, because for them the brainstem is bigger than the visual association area. So it uses the lens, compound lens in the eye, and the horizontal tilt center in the dorsal brainstem to study, have a three-dimensional view. So when there is a disconnection due to a brainstem lesion, this mechanism becomes unmasked, resulting in a vertical skew deviation. So that is one. Second, element. So element diplopia can be due to obliques or due to recti. So now when we go and examine, we'll have to look for whether it is supranuclear, nuclear. We want to know whether it is at the cranial nerve level or is it intrinsic in the brainstem. Whether it is the intrinsic in the brainstem, we don't know. So this vertical diplopia, would you like to tell? No? It can be due to element cause.
Usually if it is vertical, usually it is because of the obliques or superior recti. So if it is usually because of the obliques, usually there will be associated head tilt. And recti work maximally in abducted position. So the patient, the diplopia will be maximum during the abduction and elevation whenever it is in the rectus is involved. Whereas in the oblique, it is they work best in the adducted position. So during adduction, they work maximal. So the plane of separation will be maximum in adduction for
so first you want to know whether you told about head tilt. Head tilt in is null position adaptation. So head tilt, why head tilt happens in diplopia? It is due to adopt for maximum precision of the vision. When there is a double vision, the precision is lost. So when you tilt the head in a particular position, the diplopia becomes annulled and the object is seen much more clear. So in that plane, the eye will adopt. This happens only to two muscles. One is the lateral rectus, second is the superior oblique. So if it is due to lateral rectus palsy, there is an ipsilateral head tilt. If it is due to superior oblique palsy, there is a contralateral head tilt. So these are the two muscles which get adopted by null positioning of the head. So it is like that. So if the person says vertical diplopia, you want to know whether it is organic or functional first. So if the vertical diplopia is organic, then there will be a vertical skew. So anybody who is having a true vertical diplopia will have a vertical disconjugation. Supposing it is a psychogenic vertical diplopia, when you look at the resting eye position, what you call the resting eye position, there will be no vertical disconjugation. So you agree with the patient, he has a diplopia if there is a vertical disconjugation of the eye which is visible. So I always tell, now you know your patient has got a disconjugation. One eye is up and one eye is down. So you know that he truly has a vertical diplopia. So now what are all the muscles which could be responsible? It could be right superior rectus, right inferior rectus, right superior oblique, right inferior oblique, and similarly the left 4 muscles. So it could be 4 plus 4, 8 muscles. So when you look at the resting eye position and there is a vertical disconjugation of the eye, it is a true diplopia, and patient says that there is a null position adaptation and a point of maximum separation. So you think it is element. If it is not there, you do not know, it may be still element or human, you will have to examine. So if it is element and if there is a vertical disconjugation, 8 muscles can be taken as possible culprits. So now let us imagine that when you look at the resting eye position, the right eye is up and the left eye is down. So that is vertical disconjugation or the reverse, anyway you can take. So if the right eye is up, what it means, right inferior rectus or right superior oblique is weak. So right inferior rectus is weak, so the right eye is elevated, or right superior oblique is weak, so that the right eye is elevated. And left eye is down. So when the left eye is down, left superior rectus or left inferior oblique. So by looking at the resting eye position, from the 8 muscles as a culprit, we cut off 4 muscles. So first step is to know whether the patient's vertical diplopia complaint is true or false. For that, look at the resting eye position. If the resting eye position shows a vertical squint, that means it is true. So once you have decided it is true, then see which is up, which is down. So we'll write it down on the notebook, which eye is up, which eye is down. Based on that, which muscle is weaker. The eye will deviate in the plane of action of the stronger muscle. So that becomes the culprit. So two muscles get cut off. So from 8 muscles, we are left now with 4 muscles. Then as Vijay said, we will apply the next principle. So among all these 4 muscles, which could be the culprit? So you can say, you can again ask, if the patient is saying my double vision is one up and one tilted, then you can cut off the recti. Only the obliques produce oblique diplopia. If the patient is able to tell, by that complaint itself, the 4 muscles become 2 muscles. But if the patient is unable to tell, then you have to apply the principle that recti act better in the abducted eye and obliques act better in the adducted eye. And second principle, you know that when the paralyzed muscle is put into action, the diplopia will be maximum in that plane. So that is the 2 principles. Recti act better in the abducted and obliques act better in the adducted eye. And second, when the eye is put into maximum stretch in the plane of action of the paralyzed muscle, the double vision becomes worst in that plane. So supposing we are wanting to check the left superior rectus. So superior rectus is an elevator and it acts better in the abducted eye. So I will put my left eye abduction and elevate. So put left superior rectus is tested by telling the patient to elevate his left eye in the abducted position. Next, you have to check and ask him to find out the degree of separation between the true image and the false image. And note it down. Next, you are having the left inferior oblique. Obliques act better in the adducted eye. And left inferior oblique is a elevator in the abducted position. So you put the in the adducted position. So you put the eye into adduction and you try to do the elevation. So you do that and find out what is the maximum separation. Then you are going to the right inferior rectus. Again, recti acts better in the abducted eye and the right inferior rectus is down and out. So down and out, what is the maximum separation? Then the right superior oblique act on the adducted eye. Right superior oblique is a depressor. So you look for the right superior oblique by trying to depressing the eye in the adducted position. So check all this and maximum separation is taking place in which plane. So supposing my patient is telling, when I am looking to the left, abducted and up, then the pairing muscles are, then you know that among all the 4 planes, the maximum separation is happening when the patient is looking to the left and up. When you are looking to the left and up, you are checking the left superior rectus and the right inferior oblique. So if you take it, that is the maximum separation. So you know that the right inferior oblique has been cancelled by looking at the resting eye position only. So the culprit is that muscle. Like that, you find out in which plane the maximum separation. And if you are correctly put it, the other pair muscle is not there. The yoking muscle is already eliminated by the resting eye position. So that muscle becomes the culprit. Then you know it is the responsible muscle. So vertical disconjugation is there, maximum separation is there. That means it is element. And by putting into the plane of action of each muscle which you are considering as culprit, we can point out which muscle is involved. Then head tilt is definitely useful. So now your patient has got a vertical diplopia. Head tilt happens only in 2 muscles. One is the lateral rectus, second is the superior oblique. So if the patient has got a head tilt to the left side, as I told, the lateral rectus, it is ipsilateral tilt, oblique, it is contralateral tilt. So if the head is tilted to the left side, that itself is sufficient. It is a right superior oblique. All the patients may not be shrewd enough to tell that it is oblique. So probably by this formula, your patient has got a right superior oblique palsy. So what is the Peculiarity of the right superior oblique. One thing it is what situation superior. I am not telling this case. Just superior obliques get involved maximum in what context? Trauma, head injury, minor head injuries. It is not brain injury. So anybody following head injury with not having any features of raised intracranial pressure, but if they are saying double vision, and the double vision is vertical due and attributed to superior oblique, because the superior oblique goes through a trochlea. It is a hooked muscle, so it gets ruptured there. So commonest cause for superior oblique paralysis is trauma. And most other conditions try to spare the superior oblique. But still it can be involved, but neuromuscular junction disorders, what is the preferential? So superior oblique preferentially gets involved in trauma. Neuromuscular junction disorders involve the superior rectus and the levator. So neuromuscular junction diseases preferentially involve the superior rectus and the levators. Whereas medial rectus and the inferior oblique is thyroid ophthalmoplegia. And loya and parasitic infections, inclusion body myositis, it is lateral rectus. So superior oblique is trauma, levator and superior rectus is neuromuscular junction, medial rectus and inferior oblique is thyroid ophthalmoplegia, lateral rectus is inclusion body myositis and parasitic myositis. That just to remember. And of course, you know the other conditions where the superior orbital fissure syndrome, cavernous sinus syndrome, orbital cellulitis, all these conditions are there, which we can discuss at the end if needed. So now apparently it looks like a superior oblique palsy fitting the vertical diplopia with a head tilt. Even though common situation is superior oblique, it is not a rule. It is just an incidence. So in this case, because there is no trauma and other cranial nerves are getting involved, we will say it's a superior oblique now palsy. What is the cause? We will decide it later. It is obviously not a part of an orbital cellulitis or superior orbital fissure syndrome, because other cranial nerves are not involved. Only superior oblique is involved. Next, you said that the patient has got a slurring of speech. So at this point, again, all of you know, still we can say how to define dysarthria if there are newcomers. So dysarthria is defined as ability to convert language into audible sounds. So language is converting thoughts into comprehensible modes of communication. So thoughts are there and you convert it into comprehensible modes of communication, which involves reading, writing, listening, and speaking, repeating. So 5 components are there: repeating what others are speaking, then you are writing, you are speaking, you are reading, and you are hearing. So 5 components are there. So thoughts being converted into any of these modes of communication is language. So ability to convert thoughts into comprehensible modes of communication is language. But speech is converting language into audible sounds. So only one mode. Language should be already there. So to call it as a speech problem, language should be already there. And only one component out of these 5 limbs, that is production of the audible sounds. So audible sound component alone affected. So in this patient, obviously from what you have told, all other aspects are there. Only the sound production is affected. So it is a dysarthria. It is not a language problem. That is very clear. And dysarthria, as you know, you have got a spastic dysarthria, flaccid dysarthria, dyskinetic, ataxic, and cortical. So this is the classification: spastic, flaccid, ataxic, dyskinetic, and cortical dysarthrias are there. Flaccid dysarthria could be due to labials, linguals, gutturals, and dentals. So labials will be for, so when you study a sample of spontaneous speech, so any person with a speech disorder or a language disorder, you study a sample of spontaneous speech. That means just tell the patient to narrate his story and just listen. So during a sample of spontaneous speech, you notice that specifically when patient is pronouncing words with the P or B, the slurring becomes obvious. When he is speaking other words, there is no slurring. Then you know it is the labials. So labials can be part of a facial nerve palsy, or labials alone can be involved as part of a neuromuscular junction disease, or it can be a muscle disease, or it can be brainstem demyelination or vascular causes. So only thing you will know that the dysarthria is due to the labial muscles involvement. That is labials. Supposing you want to tell linguals, L and D, T, L, T. L and T, we always use the tongue. So lily. So whenever the words which contains the linguals, that is L and T is becoming slurred, whereas other words are all right. Then you know it's a lingual. Dental is D and T. So D and T is becoming slurred, means patient has recently become edentulous, or he has some dental pathology because of which he is not able to use the teeth. So that's a dental. Gutturals is NG, GG. So bringing, singing. So when the words which need a palatal phonation is getting affected, then you know it's a gutturals. So that is a flaccid dysarthria. Next is a spastic dysarthria. So spastic dysarthria is an effortful speech, and patient will skews out the word. He'll strain and he will skews out, and it is like speaking with a hard potato in the mouth or a lisping component. So we tell you use the word British Constitution. So it becomes British Constitution. So they strain and link. Syllables will run into one another, and a lisping component gets added with a lot of effort, and there is no separation. That is a spastic speech. Pseudobulbar palsy, which can be due to multiple infarcts and a disease. So other FTD-ALS. So these conditions you get a spastic dysarthria. Then you have got an ataxic. Ataxic could be scanning or staccato. That is cerebellar. Scanning, as the word itself says, you split a word into syllables. So commonly we tell Chakravarti Rajagopalachari. Or in Trivandrum, people will say Thiruvananthapuram Medical College. No? So like that. So sometimes they also give non-innala kollattu poi, like that they are telling in Kerala. So this Chakravarti Rajagopalachari is very, very useful. They will split it in cha, kra, va, ti, like that. That is a scanning speech. Whereas staccato speech is explosive, and speech modulation is inappropriate. So patient will stress in areas where you do not. Sometimes when we are speaking, there is a modulation, and the explosive aspect comes in the area where you want to stress. So that thing is not there. Instead, you will stress an unwanted area. That is a staccato speech. Then you have got a dyskinetic speech disorder. Under dyskinetic, you have got hypokinetic and hyperkinetic. Hypokinetic is Parkinsonism. So there is it's a manifestation of bradykinesia. Progressive decrease in the voice volume. As the patient keeps on talking, voice volume keeps on going down and down and down. Whereas other causes of altered speech volume, like vocal cord paralysis. In vocal cord paralysis, a hoarseness, which remains constant. And external laryngeal nerve palsy also produces altered speech because of the failure of modulation of the vocal cord. That is again a type of hoarseness only that can show some degree of fatigue. But what you get in hypokinetic speech is like a bradykinesia, where the speed, volume, and the amplitude steadily comes down. The speech amplitude and the volume steadily comes down. Starts very loud, slowly, 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 the voice sinks down. That is hypokinetic speech. Then you have got hyperkinetic. Under hyperkinetic, you have got the tremors, you have got the chorea, you have got the lingual dystonias, So tremor will be a lingual tremor. Now, before that progressive decline, sometimes people will mistake neuromuscular junction. Because here we are having a patient with a slurred speech, whether it's having a facial palsy and a oculomotor, whether it's neuromuscular junction, we don't know. So what happens in a neuromuscular junction is, when you start, you are normal, but it becomes dysarthria as you communicate. So the difference in hoarseness in vocal cord paralysis is remains hoarse with stridor throughout. External laryngeal nerve, it is hoarse, but it fatigues. Whereas bradykinesia, amplitude and the pitch comes down without alteration of the way in which it is spoken. Whereas in neuromuscular junction, a patient who does not have any dysarthria, as he continues to speak, he will go into a guttural type or the labial type, depending on whichever muscle is affected in that neuromuscular junction problem. So that is neuromuscular. So even though it is as you continue to speak, the speech gets altered. In all these conditions, the alteration is clearly distinguishable if only we know how to distinguish. So that is hypokinetic. Then hyperkinetic, you have got voice tremor, you have got lingual tremor. Voice tremor is a feature of senile tremor. So it's a shaky voice. Whereas lingual tremor is a tongue tremor, trombone tongue. So because of the tongue tremor, linguals become tremulous. When the patient tries to speak with the linguals, they become tremulous. That is hyperkinetic due to tongue tremor. It is different from voice tremor. Then you have got lingual chorea. So choreic speech is like all choreic movements anywhere else. Sudden unwarranted stops when the choreic movement comes. Whereas orthogonia or a lingual dystonia, it is like a writer's cramp. So when he speaks, he is all right. And halfway through the tongue twists, so speech stops. And when you look, you will find that the tongue is lying twisted in the floor of the mouth. That is orthogonia. So these are the various kinds of speech disorder. When we use the term slur, any early stage of the speech disorder will be uncharacterized. Then you call it as a slur. So when you say slur, you do not know what you are going to. Only thing you know, it's a speech disorder which is uncharacterized. So and there is something called cortical dysarthria. Cortical dysarthria is the term applied to a group of disorders. One is the cortical dysarthria of mentally retarded children. Even though they use the correct words, even though they have the proper way of pronunciation, it is like the childish speech. So child will be, what I should tell, child will be having some kind of emotional component to the normal communication. So that way of childish, konji special, that kind of speech, it is a cortical dysarthria, mentally retarded children. Then even the speech apraxia is one type of cortical dysarthria, where the patient has a very peculiar type of dysarthria, and they put odd movements of the orofacial muscles when they are trying to speak. But this is called as speech dysarthria because the speech quality is altered. The muscles are put into odd movements, but when they are swallowing or when they are using their facial muscles for any other activity, the movement is normal. So unlike any other dyskinesia or any neuroparalytic condition, there is a voluntary reflex dissociation in any apraxia. So only for speech, the muscles are improperly attributed. So during speaking, the person will recruit wrong muscles and hold very grossly abnormal postures. But when he has to use the same muscles for other activities, it is normal. That is apraxia of speech commonly seen in corticobasal degeneration, frontotemporal dementias. That is apraxia. Another cortical dysarthria is disconnection of the motor speech area from the rest of the brain, which happens in acute conditions. So these are cortical dysarthria. So what is our dysarthria? We'll examine and find out. You told that the patient is unable, difficult in mixing food bolus in the mouth. So what exactly was the difficulty? Was he able to chew? So at that time, we can say whether the patient is able to chew. When he is chewing, if the chewing is all right, the medial pterygoid, lateral pterygoid, masseter, and temporalis are all right. For chewing, we use the muscles of mastication. So if they are all right, if the patient is able to chew the food properly, the muscles of mastication are all right. So after having chewed, if the food is remaining in the gingivo buccal gutter, buccinator is weak. If the food is leaking to the sides of the angle of the mouth, it is the orbicularis oris. If none of these things are happening, but patient then the facial muscles innervated by the facial nerve is all right. If the patient says all this is all right, but I am not able to push the chewed food into the pharynx, then it is the tongue. If all this is also all right, but I am not able to direct the food into the esophagus, it is the pharyngeal phase. I am coughing when I am trying to put the food into the esophagus. I am able to chew, I am not leaking. I have thrown the food bolus into the pharynx, but when I try to put it into, swallow it, I am coughing or having nasal regurgitation, it is pharyngeal phase. Even that is all right, but when the food goes into the esophagus, it becomes stuck, means it is esophageal phase. So you said that difficulty in making a food bolus or mixing of the food in the tongue. So maybe it is in the lingual phase, apparently. Because your chewing seems to be all right, other aspects are all right. So it is in the oral phase. Patient has problem in the oral phase of swallowing, and in the oral phase, it is in the third part, that is making the chewed food into a bolus and pushing it posteriorly. So probably it is the 12th nerve, we can say. So when you tell that history, you can put one word, chewing is all right. There is no leaking of food. But when the food is reaching the floor of the mouth, patient is unable to push it posteriorly. That will make the information little more clear. So it looks like a oral phase. So it may be a lingual, which you have already committed also. So it may be lingual. Okay, so now there is a short duration illness in a patient who has undergone a recent vaccination, and apparently one cranial nerve and one cranial nerve in the oculomotor group and one lower cranial nerve. It is a lingual. Is it unilateral or bilateral, or is it LMN or UMN? All those things we will have to examine and decide. Any long track signs? No long track signs. You
No long track signs.
So these are not contiguous. So one is in the midbrain region, and another is in the medulla. In between the pondine area, you are not having any cranial nerve palsy. So widely separated two cranial nerves. So it is multiple cranial nerve palsy. Is it intrinsic or extrinsic? We will have to decide. Is it involved multiple lesions in the brainstem? Means you should look for other features of brainstem involvement during examination. So if you do not find any evidence for any brainstem involvement, it is polyneuritis cranialis, because it is monophasic. Classical polyneuritis cranialis will be polyphasic. At one time, patient will have seventh nerve, then he will improve with that, and after some 1 year or 2 years, he develops another cranial nerve. So they will keep on knocking out many cranial nerves one by one, which are not contiguous without any intrinsic features, and it happens over several months or years. Whereas these two cranial nerves are knocked out in one time. So, and he has a history of vaccine. So more than sarcoid and other things, I would still like to consider a post-vaccinal condition where you can have Guillain-Barré-like, or it can be cranial neuropathy. When you have radicular neuropathy, it is Guillain-Barré-like syndrome. You can have Miller-Fisher-like syndromes. You can have even individual cranial nerve palsy. So is it a multiple cranial nerve palsy as a manifestation of post-vaccinal demyelination? That too, mostly I have seen with the Covishield more than Covaxin, and Sputnik also. We have seen it Sputnik also more. Covaxin I have found least. But one thing, we have gathered our cases, but I feel that the number of Covaxin cases are also less. Many people have taken Covishield. So the value doesn't come as statistically different because the number is not matching between Covishield and Covaxin. But still it may match when more number of people take Covaxin, and then we will see whether they are also getting all these things or not. Then we will be able to compare. So my first diagnosis, probably it is multiple cranial nerve palsy post-vaccinal demyelination, and other possibilities become a theoretical differential diagnosis. That is what I will think of. Okay, then we will examine, but we are not sure unless we examine. We don't know whether the other brainstem features are there. Young person, middle-aged person, whether she is having the first episode of a brainstem cerebellar demyelination as a manifestation of MS, where you can have a disseminated lesion. So you can have one lesion in the upper brainstem, one lesion in the lower brainstem, and other features may not be seen. So that is whether it is a brainstem form of MS, and the whole thing becomes lower cranial nerves will not be involved, but cranial nerve symptoms can be present when the plaque sits in the cranial nerve exit zone. Yes, as you know, primary demyelinating diseases primarily affect the upper motor neuron. But they present with the cranial nerve symptoms now because the plaque sits in the nerve exit zones. And brainstem cerebellar form is the commonest form, considering the age of the person, whether it is the first episode and a disseminated lesion. So when we examine, if you are surprised and we find exaggerated reflexes, mild cerebellar signs, and so many things, if you are finding on examination, then it becomes an intrinsic problem. And the plaque may be sitting in the nerve exit zone. Her age group is suiting. How old is she?
43.
43 is little older for that. If it is 33 or so, that becomes a possibility. Many times people come with double vision and you think it's a lower cranial palsy, and then you do an imaging, you find a brainstem lesion, and that becomes the first episode of primary demyelinating disorders. So it is not at all uncommon, but she's 43, is little older. So when you examine, if you find intrinsic signs, our differential diagnosis will be a little more different. Brainstem demyelination, sarcoid, okay, they are SOL, because you know that you are correct in one sense that tumors grow vertically. Brainstem tumors grow vertically and not transversely. So because of that, it can be a great imitator, especially in children. So a child will come with a 6 nerve palsy once, and you give a short course of steroid, the child becomes all right. You don't find any other signs. And after some time, child comes with another cranial nerve. They may show partial response to steroid, especially if they are lymphomas and things like that. They may respond to steroid for some time. So you will think it is only a lower cranial palsy and give a steroid, because they grow vertically and most of the cranial nerves are ventrally placed. So they can present with the cranial nerve like, because the tumors grow vertically and not transversely. Most of the brainstem tumors, unlike the hemispheric tumors, brainstem tumors grow downwards. Otherwise, SOL is very much less likely in this age group. Children, it is common. So that my teacher is to tell, when any child comes with a 6th nerve palsy, before putting the child on steroid, examine the abdominal reflex. Because the abdominal reflex is very sensitive in children. They have got a very good muscle. It has not become lax due to fat or old age or pregnancy or delivery. All those things are not operating. They will have very good abdominal reflex. So a child with a 6th nerve palsy, you do the abdominal reflex. Other signs may not be there. And abdominal reflex is fatiguing easily or not there. Then you think of a brainstem glioma. You'll have to do the imaging. Because when those days when we are students, all these are not very easy. We have to do pneumoencephalography. When I studied in Madurai Medical College, I did DM in Madurai Medical College. So there we have to do pneumoencephalogram. You have to inject air into the subarachnoid space, and that is called, the air will go and occupy the cysternal spaces. Supposing there is a brainstem glioma, air will get trapped. Air will not go into the space around the brain, midbrain. Then you know, okay, the brainstem is swollen. Like that. It is a very painful procedure for the patient because you are injecting air. Severe headache they will have. That is pneumoencephalogram. And MRI was available only in Mumbai or some places. When we were studying, it was not there. CT was there, MRI was not there. So it is difficult. So this sign used to be very, very useful. So if you find an absent abdominal reflex, you will insist that it is something serious. Otherwise, in this patient with available localization, SOL is less likely. Even N-block meningiomas, nothing I am considering. Sarcoid, okay, sarcoid is for any cranial nerve palsy, any other granulomatous conditions, a possibility is there. So first I will be considering post-vaccine and all other things in that order. Okay. So go to examine.
A patient is moderately built and nourished, well oriented to time, place, and person. No pallor-ectorous cyanosis, clubbing, lymphadenopathy, or edema. BP was 130 by 70 millimeters of mercury. Pulse was regular, 87 beats per minute. There is, on head-to-toe examination, there is no any feature suggestion of any autoimmune disease. Like no hair, skin, nails, tongue, teeth, tonsil are all normal. Coming to the neurological examination, higher mental functions are normal. MS is 27 by 30. Cranial nerve examination, that video is only I could get one video. In cranial nerve examination, patient was not reluctant to give the ocular face video, but this one.
Looking at this, the tongue looks
Deviated in the mouth. It is deviated to the right, ma'am. But on protrusion, it is moving to the left with some atrophy that is there.
Let put it. It is clearly deviating to the left side when she is putting out the tongue, and inside you put it.
Yes.
Inside view you can show. Inside.
Yes.
Okay, very clear. This is very good for undergraduate demonstration. This is clearly element. Why this happens? Would you like to tell, ma? So very you should teach the undergraduate students.
When the tongue is placed inside the oral cavity, the intrinsic muscles of the tongue will be acting, madam. So that time weakness on the left side means so the tongue will be moved. Whichever side is stronger, that side the tongue will be deviated. Whereas when the protrusion is happening, the genioglossus will act. That actually pushes the tongue, opposite action. So when the tongue is protruded outside, the tongue deviates on the same side of the lesion, because the left side genioglossus will be weak. So the right side genioglossus will act and it will push the tongue towards the left side.
Is there any mistake in what you said? Umpires are all good only. You see, first thing, as you say, when you put out the tongue, what muscle is acting? When you put in the tongue, what muscle is acting? And when are the intrinsic muscles acting? When you put out the tongue, I agree it is genioglossus. And the right genioglossus will push the tongue to the left side. And left genioglossus will push the tongue to the right side. And it works when the tongue is out. When the tongue is inside, it is the hyoglossus. Hyoglossus assisted by the chondroglossus and styloglossus for the posterior part. But mainly it is the hyoglossus that moves the tongue to the same side only. Left hyoglossus will move the tongue to the left side and right hyoglossus will move the tongue to the right side. But what are the intrinsic muscles doing? You have got verticalis and transversalis. and longitudinalis. They are the intrinsic muscles. These intrinsic muscles give shape to the tongue, and they are the muscles involved in the fine movement of the tongue, like rolling of the tongue from side to side, or rolling of the tongue anterior-posterior. So that is intrinsic muscle. So what happens in this situation is, as you rightly said, now the patient's tongue is out. So it is the right hyoglossus which is pushing the tongue to the left side. So the tongue is deviated to the left side. When the tongue is put inside, what happens? Right hyoglossus will keep it on the right side. Left hyoglossus will keep it on the left side. Now the tongue is deviating to the right side. That means right hyoglossus is strong. Left hyoglossus is weak. So it is the difference between the genioglossus and the hyoglossus, not the intrinsic muscle. You told it is intrinsic muscle. Intrinsic muscle has got a different action. It is hyoglossus which positions the muscle inside the tongue, and genioglossus outside the tongue. And genioglossus moves the tongue to the opposite side, and hyoglossus moves the tongue ipsilaterally. And this muscle paralysis is a feature of LMN. So always, if you have to differentiate between UMN and LMN, we tell UMN is movement paralysis, whereas LMN is muscle paralysis. So in UMN, movement to the opposite side is paralyzed, not muscle. So whether it is genioglossus or hyoglossus, it is immaterial. So in UMN, whether you put the tongue outside or you put the tongue inside, the plane of deviation is same. It does not differ based on whether the tongue is inside or outside. So if the tongue deviation changes based on whether the tongue is kept inside the mouth or outside the mouth, it is always LMN. That indicates there is muscle paralysis, not movement paralysis. If the we told during our discussion, are we going to have a surprise? Is the patient going to have some brainstem features? So that question, or is it an upper motor? So if it is an upper motor neuron problem, then the deviation will not vary like this between the tongue kept inside and kept outside, because it is movement paralysis and not muscle paralysis. So to differentiate LMN from UMN, 12th nerve palsy, one is atrophy, atrophy or wasting, then fibrillations, flaccid tongue when you palpate. So LMN 12th nerve will be palpable, flaccid, and it is fibrillating, it is wasted, and if it is unilateral LMN, it will show differential movement when the tongue is kept inside and outside. If it is upper motor neuron, there is no wasting, but the tongue is spastic, it is shrunk inside the floor of the mouth, and the deviation, if it is unilateral, deviation inside or outside is the same plane. So that is the way to differentiate LMN from UMN. So this is clearly a classical undergraduate demonstration of an LMN 12th nerve palsy. Okay, next one.
We did that Park's 3-step test to localize a single muscle that if it is involved. So in this, on primary gaze, there was a right vertical, the eye was divided upwards, the right eye was divided upwards, along with the head tilt towards the left, and the diplopia was maximum on down and left. So we got localization as the right superior oblique.
Yes.
And apart from that, no other cranial nerves were involved. Corneal reflex also was normal. Facial sensation was normal. Apart from that, the other lower cranial nerves were all normal. The 9th, 10th gag was equal. There was no deviation. The trapezius and sternum mastoid was normal. Motor system attitude, there was no muscle wasting that was noted. Nutrition, it was normal both sides. Power also was normal. All the groups of muscles were normal, both the upper limb and lower limb, no long tract side. Sensory system also was normal. Cerebellum was normal. There was no issue with the cerebellum. Coordination normal. Gait was normal. Cortical sensations were intact. Other system examination also was normal.
Okay.
Clinical
You
diagnosis.
do not have anything to suggest a brainstem involvement or any other part of the neuron. So it's a multiple cranial nerve as you thought. So any other system features are not there. Did you find any mediastinal adenopathy and other things which you said? Non-reactive, non-reactive. So what do you think this is? I still feel it is vaccinal. I have seen 12th nerve.
At the end of this, we were also thinking, we gave a short pulse course of steroids. After that, patient said the diplopia gradually worsened. On follow-up, the diplopia had improved. Tongue was still there, the weakness was still there. But we were also thinking at the end of that, we were also not sure, thinking maybe it is vaccine related.
I have a doctor who developed tongue atrophy. He was an Ayurvedic doctor. So somebody diagnosed motor neuron disease. He took Sputnik vaccine, clearly Sputnik. And imagine giving the diagnosis MND. He's Ayurvedic only, but he knows what is MND. He was so scared. But he had patchy sensory symptoms in the trunk. But it was like a soft sign. But he had multiple lesions. And he became anti-Rho positive. And later he developed something like an ulcerative colitis. So I thought triggering of immune dysregulation following this vaccine. He was working in another country and he took Sputnik vaccine and then came here. But everything settled down by about 3 months. So I feel it is vaccine related only. I feel so. Other features are not there. You said all those differential diagnoses. But I think this case is a very good demonstration of a classical element 12th nerve palsy. So now you can, I always tell now, supranuclear, nuclear, intraaxial, fascicular, cysternal, skull base, foraminal, soft tissue plane. That you can do a revision. Various foraminas are there, hypoglossal canal is there, you have got various syndromes of so many cranial nerves. So that just go through a revision. Human versus element, we thought transiently you can get human 12th nerve palsy like facial palsy in some patients with hemiplegia. Not common, but occasionally you can get. Otherwise, it is part of pseudobulbar palsy or ALS, those conditions you get. But just to trace the 12th nerve also from the homunculus down to the brainstem to the skull base. So supranuclear, nuclear, intraaxial, fascicular, cysternal, skull base, foraminal, soft tissue plane. So up to the soft tissue plane, do not forget, because that also my teachers, K. Srinivasan sir, Madurai, he is still the best neurologist in the country, I think. Wonderful clinician, but some of the unsung heroes in neurology in India. So he always told me, when you have a tongue like only tongue is involved, and you think it is a motor neuron disease, and always lift up the tongue and see. You see, this is such a wonderful point for shrewd clinicians. So I have picked up to 2 cases labeled MND NIMHANS by going through this course. So only tongue, over period also nothing is getting involved. So what is that MND? Nobody picked up the tongue. When we lifted the tongue, there is a salivary gland tumor. So soft tissue plane, never forget, treatment is totally different. Patient came to NIMHANS, so he is labeled MND. So anywhere, let it be Mayo Clinic or any center in the world, do not forget the template. So this template, my teacher, he will ring in my ears. He is the best neurologist. If God permits, you all meet him once. K. Srinivasan Madurai. Such a wonderful teacher. So I have picked up 2 cases. One was a salivary gland tumor, another was a lymph node, which turned out to be lymphoma. So you find a shrunken tongue, and so it is a bulbar onset M&D. It becomes a bulbar onset M&D, and you are waiting for the other things to evolve. Instead, patient will have a treatable disease. No? So supranuclear, nuclear, intraaxial fascicular, cisternal, skull base, foraminal, and soft tissue. Every cranial nerve, other than the first and the second, can be placed in these planes, and each plane has got a group of differential diagnosis. So that you have to, for 12th nerve, this is the thing. Always lift up. If any other cranial is not getting involved, lift up the tongue and see. Very important. So good. Any questions?
One, like, how would we approach any, like, if it is multiple cranial nerve palsy, it is like, how do we have the broad approach to that? Here, this patient.
Okay, you have to multiple cranial nerve palsy. One, is it disseminated in time and space? The classical cranial neuritis, polycranial is multiplex is disseminated in time and space. One will be on the right side, one will be on the left side. Supposing you are having no dissemination in time and contiguous cranial nerve palsies. So cranial nerves which are adjoining are getting involved. Always think of a granulomatous or neoplastic infiltrative lesions. So if it is unilateral, contiguous, not temporally separated, it is always due to an underlying pathology. If pathology of demonstrable nature, whereas it is disseminated in time, disseminated in space, or both sides, non-contiguous, then you think of the non-specific varieties, as well as the demyelinations. Granulomatous infiltrations can be self-limited sometimes, come and go. So all these will be coming, going. So contiguous, not temporally and spatially dissociated, do all your techniques to look for an infiltrating lesion. If they are disseminating, relapsing, they are non-specific cranial polyneuritis or all those demyelinating things which can come and go, sometimes self-limited. Anybody will give steroid, it will get subsided and come back again. That is how, otherwise the localization, all these foraminal company is there. In various sessions you have discussed, one plane, one group of cranial nerves come together. So is it getting the features of a superior orbital fissure, or is it having the features of a jugular foramen, or is it having features of a Collet-Sickard syndrome, retrocondylar space? So all on area you have got conglomeration of cranial nerves which get involved. So depending on that, you look for the appropriate pathology. That is a contiguous, same side, not temporarily dispersed. Always look for a structural pathology. Non-contiguous, temporarily dispersed, it may be demyelination, the non-specific granulomatous disorders, vasculitic conditions, post-infectious demyelinations. Those things become differential diagnosis. Any other?
Intrinsic, this one is the presence of brainstem.
Intrinsic, as I told, no. Cranial nerve palsies from the ventral plane in children. It can resemble very much. 6th and 7th may get involved. So something like that. Child is not having any other long tract. Children, it is very important. Brainstem gliomas, children, because they grow vertically, not transversely. Otherwise, if you always look for intrinsic feature, patient might tell diplopia, patient might tell dysarthria. When you examine, you may demonstrate cerebellum. You may demonstrate, because many times I have seen brainstem cerebellar type of MS, because they are small lesions, patchy lesions. They can be missed and mistaken as a non-specific Bell's palsy or 6th nerve palsy. Unless you are very careful and look for soft intrinsic signs, you might mix it. But just remember, that's all, always remember that. Any other question?
One question, can you please discuss side of tongue deviation in left-sided UMN palsy versus left-sided LMN palsy of 12th nerve?
Left-sided LMN palsy of 12th nerve, when the tongue is put out, tongue will deviate to the left side. When the tongue is kept inside, tongue will deviate to the right side. Whereas left-sided human the tongue will deviate to the right side, whether it is inside or outside.
One more question was, can we differentiate between cerebellar nystagmus from central vestibular nystagmus?
Certainly you can differentiate. You see, cerebellar nystagmus is classical cerebellar nystagmus is gaze evoked, because cerebellum monitors the rate, range, rhythm, direction, and amplitude of any movement, including eye movement. So rate, range, rhythm, direction, and amplitude of any movement, including eye movement, is monitored by the cerebellum. So when you have decided that I want to look at Vijay now, I know that till I finish this sentence, I want to look at him. So there is a temporal spatial coding. That rate, range, rhythm, direction is decided by cerebellum. So when the cerebellum is sick, we call it as a leaky neural integrator. Cerebellum is one of the part of the neural integrator, apart from PPR, nucleus magnocellular, which we call it as a 3-neuron arc. So the neural integrator will leak. So when I look to the right side, it doesn't hold my eye on the target of interest for sufficient period of time, because the rate, range, rhythm, direction is planned wrongly. So it will go there and it will come back. When I look to the left side also, it doesn't remain like that. So it's a gaze evoked nystagmus. So when you look to the right side, the fast component to the right side. And when you look to the left side, the fast component to the left side. When you look up, the fast component is up. When you look down, the fast component is down. So it's a gaze evoked nystagmus, means fast component of the nystagmus is in the plane of action of gaze. That is classically cerebellar. Of course, cerebellum has got other types of nystagmus which are less common, depending on the involvement of the nodule and things like that. But what is the vestibular nystagmus? So classical cerebellar nystagmus is gaze evoked nystagmus, which means that the fast component is always in the plane of gaze. When I look to the right, it is fast to the right. When I look to the left, it is fast to the left. Then you come to the vestibular. You have got peripheral vestibular and central vestibular. Peripheral vestibular, the slow component is always to the paralyzed side. So supposing I have a peripheral vestibular dysfunction on the right side. When I look to the left side, my nystagmus fast component to the left side and slow component to the right side. And when I look to the right side, again, the slow component is to the right side and fast component is the left side. So irrespective of the plane of gaze, the slow component is to the side of pathology in peripheral vestibular. In cerebellar, fast component respects the plane of gaze. Which direction I am looking, that direction is the fast component. Whereas peripheral vestibular, fast component irrespective of the gaze. So peripheral vestibular does not respect the gaze. Peripheral vestibular, irrespective of the gaze deviation, slow component is always to the side of pathology. Central vestibular is dissociated. As you know, the vestibular nuclear complex consists of 4 nuclear groups which coordinate different planes of eye movement. So you can have purely downbeat nystagmus, purely upbeat nystagmus, purely rotary nystagmus, and it does not have a slow component to any plane or fast component to any plane. So central vestibular is purely vertical, purely down, purely up, purely rotary, and it neither respects the disease pathology nor respects the gaze pathology, like cerebral. That is how you differentiate. Central vestibular is based on the nuclear complex. Peripheral vestibular is based on the push-pull mechanism. That eye movement talk will be there in the video, I think, in your YouTube. There you see I have explained the mechanisms why slow component goes to the side of pathology in peripheral, and each one I have described in that talk. Any other question?
One question one person has asked is how to differentiate seventh nerve UMN versus element unrelated to this.
Which one, ma? 11th nerve.
Seventh.
7th nerve? Which one?
UMN versus element.
Seventh nerve, UMN, all of you know that it is the lower facial paralysis, UMN, whereas LMN, it is a pan-facial paralysis, generally. Unlike you have got a Hansen's disease where the branches become paralyzed or parotid tumors. Otherwise, LMN facial is pan-facial, whereas UMN facial is lower facial. Second point, you will have no accompaniments in UMN like hyperacusis or taste or tears. Whereas in LMN, depending on the level in which the seventh nerve is involved, you can have loss of taste, you can have hyperacusis, you can have altered tear secretion. So these are which hitchhack the seventh nerve in the various extra-axial course of the seventh nerve will not be involved in UMN. Whereas in the UMN, you usually have a corticospinal tract involvement. In the LMN, corticospinal tract doesn't get involved. Then you look at the this one, Bell's phenomena. If you look at the Bell's phenomena is again, it is due to when you close the eyes roll up normally. That is a physiological synkinesis between the orbicularis oculi and the superior rectus. Orbicularis oculi is supplied by the seventh nerve. Superior rectus is supplied by the third nerve. These are two different nerves. They have a physiological synkinesis. Therefore, they are called yoked muscles. Just like I told in the 12th nerve, there is muscle paralysis in LMN. There is movement paralysis in UMN. So when there is a muscle paralysis, when one muscle is strong and the other muscle is weak, the yoked muscles move in favor of the unaffected muscle. So when you close the eyes, the eye on the side of paralysis will move much more. If the eyes move much more than normal, then it is Bell's phenomena, it is element. So pan-facial presence of Bell's phenomena, then involvement of the other accompaniments like taste, hyperacusis, tear secretion, and absence of pyramidal involvement is favoring element, whereas UMN is lower face, accompaniment is pyramidal, there is no Bell's palsy, and of course you can see that eyes involvement, that is the difference pan-facial and the lower facial I said. So these points help you to differentiate element from UMN.
Question.
Bilateral element, bilateral UMN. Of course, when it is bilateral UMN, Bell's phenomena is not useful. You will have bipyramidal signs usually. Facial reflexes will be exaggerated. When it is a bilateral UMN facial palsy, you will find that facial reflexes are exaggerated. One additional point I forgot to tell, that is the emotional versus motor. In LMN paralysis, both the emotions and motor paralysis happens. Whereas if there is a differential involvement of the emotion and motor, it is always UMN. And so bilateral UMN, bilateral element, bilateral UMN Bell's phenomena is not anymore useful to differentiate between LMN and UMN because it is bilateral. So bilateral facial reflexes, corneal, conjunctival, jaw, globular, exaggerated is bilateral UMN. Second, mimic facial palsy versus motor. So dissociation between motor and emotional again favors, like Parkinsonian patients. They have emotional paralysis. That is UMN. So pure emotional or pure motor. So differential involvement is UMN. Then accompanying pyramidal signs. Bilateral LMN, facial reflexes are depressed. Accompaniments may be there. Corticospinal tract is not involved. Always combined emotional and motor. That is all. Any other question?
One they've asked is, can you describe the headings under which any cranial palsy has to be described?
That is my favorite, Supra. Just now I told now.
Yes.
Other
just
than the
want to know.
first and the second cranial nerve, all cranial nerves you take your braces or Dijon and see very clearly traced, but it is not in the way we want. They describe elaborate theory, but you have to read it 4 or 5 times. You read it, then put supranuclear, nuclear, intraaxial fascicular. Supranuclear means UMN. Nuclear means when they land on the nuclei. Intraaxial fascicular means between the nucleus and before they get into the cysternal space. So that is still inside the parenchyma of the brain or the brainstem. That is intraaxial fascicular. Cysternal means it has exited out of the structure in which the nucleus is there. Then it goes into the skull base. Then it goes into so many phenomena. Then comes out through soft tissues. So every cranial nerve, I tell that supranuclear, nuclear, intraaxial fascicular, cysternal, skull base, foraminal, soft tissue plane. In all these places, the company it keeps and the pattern of fiber arrangement is different for all the cranial nerves other than first and second. That you have to read 3-4 times and fix it in your brain, then neurology will become beautifully mathematics. Any other question, ma?
No other question. No other question.
Thank you, because I thought your exam is coming. You will not have time to take any case, and I will become too old, demented or something, and I will lose my time with all of you. So I thought I will do something if you are not taking a case. That's what I thought. Because 4 classes you cancel, no? Anyway, doesn't matter. Thank you for taking.
Thank you, madam. Thank you so much for teaching us.
Okay. Thank you.
Thank you.
That one day I will show you in the next class that boy I presented as a clubfoot. Now he is driving motorcycle. He's only 2 years. He has recovered so well. Proximal renal tubular acidosis. So his legs have become so fantastic. He has the plagiocephaly with Arnold Chiari malformation. That was because of the soft bone. It has gone up, and he is driving a battery operated motorcycle. Yes. So nice. Thank you. Thank you.
Thank you, madam. Thank you.